Welcome back, and a big thank you to all our speakers during our 4 days of summit. And now, for 2 days, we have had different workshops working in the afternoons. To be as precise, we've had 8 different workshops that have been working. And we are now eager to hear from all of those workshops, what they have been doing and what the result is. And we will have a short summary for about 5 minutes from each workshop, and the full summary, the full report from the workshops will then be published in the full report, the post-conference report, in a couple of months. But now let's first see and hear from the workshops that works on Tuesday. And the first is implementation of physical activity on prescription. And here with me in the studio, welcome, is Lena Kallings. You are Associate Professor at the Swedish School of Sport and Health Science. Welcome. Please tell us about your workshop.
Thank you for the presentation. And I'm glad to be here and present what we discussed in our workshop, implementation of Swedish method physical activity on prescription. And first, we discussed evidence of physical activity and mental health. And we conclude that physical activity and also physical activity on prescription can be used to create and maintain mental health. And there are enough evidence that physical activity promotes mental health, reduces risk and symptoms of mental illness and also comorbidities. We could also see that the physical activity on prescription method is evidence-based. It increases physical activity and also health. And other studies have shown that the method is appreciated by both patients and prescribers, the healthcare workers. And when we come to the implementation of the physical activity on prescription, it's crucial to use all 5 core components, to use the whole concept. And all the work should be person-centered and individualized counseling, individualized prescription, and also individualized follow-up. And to help the prescriber, we have a handbook, the FYS, it's called. It's about physical activity and health, and also recommendation for physical activity in different diseases, and for both prevention and treatment of diseases. Around 30 chapters it is. It is also important that the healthcare work together with the society to make a supporting environment for the patient to be and maintain a physical active lifestyle. And if you want to implement the method in another country, it is important that you use all the 5 components, but you need to adapt to the specific country's healthcare organization, the culture, etc. But you need to remember to use all 5 components that are experienced from the countries that are using the method now and trying to implement it. We also could see in the discussion that it's important to make a supportive environment both for healthcare workers and for the patients, and to make the different organizations to support it. We could also see, or we know, and that is very glad to see, that the physical activity on prescription, the Swedish method, is selected as a best practice by the World Health Organization, the EU Commission, and also OECD. And we're very glad that it's a large international interest in the method. At the moment, 9 different countries in the EU are now implementing the Swedish method physical activity on prescription. And in our workshop, we had 4 delegates from different countries from the EU project. And in the workshop, we had participants from Europe, Africa, Asia, and Canada. And we have earlier been interest also from the Middle East and the US. So we're very glad that we have a lot of interest. And I would also want to stress, if you want to work with a method, it's very important to have an individualized approach all the time. Although the physical activity could be either everyday activities or exercise in groups or individual, depending on the person, what they want, what is possible and so supportive for them. Thank you. A very short summary of the whole workshop.
Yes, thank you. But we will have the full report later on then. Just one question. You talked a bit about different countries. What are your thoughts on getting this out to other countries in Sweden, and what did you in the workshop say about that?
Yes, we know that the Swedish method is the evidence-based, and other countries have similar methods, but we have shown much longer effects on physical activity and health. So that's why that is selected as a best practice.
Very well. Thank you so much for this. As I said in the post-conference report, we will have the full report from your workshop. Thank you so much for being here. And now we will listen in on the second workshop. And that was called Psychological Flexibility, Mental Health, COVID-19 and Beyond. Welcome, Felicia. And Felicia Sundström, you're a PhD student at the Department of Psychology here at the university.
Correct.
Tell us about your workshop.
Of course, a very short summary this time, but I'm very happy to give it to you. So during the workshop, Psychological Flexibility, Mental Health, COVID-19 and Beyond, we had several interesting discussions spanning from what we have learned from the pandemic to how we should disseminate relevant knowledge and implement existing prevention and intervention methods. Something that several attendees mentioned, and also presenters, is the notion that young people seem to be one of the most affected groups in regards to mental health effects of the pandemic. So being young, but also being a healthcare worker and feelings of isolation was something that, regardless of continent, seems to be a vulnerable position during and in the aftermath of the pandemic. We also got exciting insights on how mobile applications, in combination with collaborations with schools, can provide a viable alternative for spreading the knowledge and enhance psychological flexibility in young people. But also, these topics must be seen from a wider perspective. We can also see that there are clear needs for widely applicable solutions for world health and well-being that can be scaled up and made accessible regardless of local resources, such as a stable internet connection. In many countries, mental health and human behavior are not always appreciated or prioritized. There is much work to be done in regards to awareness building of mental health as an important issue and the potential of behavioral science. And in some ways, the question of how we should promote the value of behavioral science is problem number one, before behavioral science can then better address mental health and other problems. So to summarize, we have learned that the world is fragile, and how people have been affected and what efforts should be made in order to spread the word does not have a one-size-fits-all solution. Even if we can identify some global trends in how the pandemic has affected us, we need to adopt an international and contextual perspective in order to be successful in implementing and disseminate existing and future intervention and prevention methods.
Thank you. Thank you so much. Was it a good workshop, do you think?
A really good workshop.
Yeah.
It was amazing. Excellent. So many interesting discussions, and we had delegates even from Zambia. So it was really interesting to see how people have treated the aftermath of the pandemic in different continents and compare it to Sweden, for example.
Excellent. Thank you so much. And your full report will also come later.
Yes, of
Thank
course.
you so much for
Thank
this. And now for the next workshop, Public Mental Health, discussion on semantics on mental health. Welcome, Simon Cervenka, professor in psychiatry here at Uppsala University. Tell us about your workshop.
So our workshop was very interdisciplinary, with representation from several different organizations from different parts of the world. And we can try to summarize it if you have the next slide.
I think you can.
Okay, great.
Yes.
So again, very brief summary of the discussions. So monitoring mental health at the population level is considered important. It could lead to intervention and prevention programs. It is challenging. It's highly contextual dependent and could be modified by socioeconomic or cultural factors. So really it's a question of the definition of what is a good life, and that can vary. There is an interaction between connotations of mental health, mental well-being, and mental ill health, and this needs to be further explored. And one suggestion from this group was, could perhaps mental capital replace the term mental health? So one comment was also that rapidly emerging new areas, so for instance neurodevelopmental disorders, could occupy a large part of the resources without prior ethical reflection and prioritization of the medical society, and that it was important that the core of psychiatry, for instance, the detection and treatment of severe psychotic disorders, that they should not be pushed aside. So moving on the same topic, taxonomy and criteria for disease. So incorrect terms and semantics could cause stigma, imprecision and false security, and also in fact wrong treatment decisions. So this means that there needs to be a an increased knowledge about basic knowledge about semantics among professionals, and that variations in the granularity of criteria may be a problem, and depending on the context of their use and the understanding of their use. I think one comment was that distress and impairment, they could be considered core criteria for differentiating between mental ill health and mental disorders. Since mental disorders are expressed differently among or across individuals, for instance, due to different loadings on vulnerability dimensions, biological markers could help to differentiate subtypes and also inform progress. And this could also be the case with verbal and non-verbal information from recorded psychological therapy sessions, and this could be a topic for analysis using AI. So moving to the part of the workshop which was more about new techniques and their applications. Following up on the previous slide, it was considered that combining big data from epidemiology and prevention and healthcare and combine this with data-driven approaches could be used to somehow reboot the taxonomy. And also, one important thing was to consider that integrity issues could be an obstacle here. Precision medicine has the potential to really generate more directed. Sorry, it's very small text to see. It could be important in generating more directed treatments and adapted treatment strategies. And I think this comment was made also by saying that the development in neuroscience and genetics by itself may not necessarily translate directly into new treatments because of the complexity of psychiatric disorders. So mental health and psychiatric illness are a strongly multidisciplinary area with psychiatrists and psychologists working together, but that also data scientists and social scientists and philosophers also should be considered and included in research teams. Digitalization is probably very, very valuable for long-distance medicine and algorithms for diagnosis and clinical decisions during treatment, and also predictive data algorithms and evaluative models, as well as etiological research. But this group wanted to warn against uncritical enthusiasm for all e-solutions. And finally, we have to properly evaluate new techniques and measures. And here it was stressed really that randomized controlled trials are of high importance, but also qualitative research was highlighted, and that this should be included also in large systematic reviews. So that was about what I could summarize from our workshop.
Thank you. And I know it's difficult to make 5 minutes out of the entire workshop.
Yes.
Yeah. So we will have the full report later on.
Yep.
And I guess that you enjoyed also having participants from different countries.
That's right.
Yeah. And was there high discussions, or did you agree on the most?
Well, depending on the digital format, we as moderators we were unfortunately not able to follow the discussions. But I think we could have had long discussions afterwards. I mean, it was such a breadth of different topics and different people from different disciplines. So I think it was very rewarding.
Interesting.
Okay.
Thank you so much.
Thank you.
Thank you for that. And now to the next workshop, hormones and mood. And now I think that we have via Zoom with us Erika Komasko, Assistant Professor Molecular Psychiatry here at Uppsala University. Erika, please tell us about your workshop.
Thank you, and good afternoon to everyone. Yes, we have been happily organizing workshop on hormones and mood in line with the recently established center focus, WOMB-HER, women's mental health during the reproductive years. And in a nutshell, we have been going through the psychoneuroendocrinology of women, and we agreed on the need to increase awareness regarding the challenges that the reproductive life brings along for women, as well as on the need for targeted research on women, as well as on personalized care, so sex-specific treatments. And we have done this while talking about the menstrual cycle, pregnancy, the postpartum period, and the menopausal transition. Our discussion has been going through and surrounding these 4 points, whether are all women affected in a similar way, by which means we could increase the knowledge gap on women's mental health, what strategies could be implemented to support the well-being of women sensitive to hormonal fluctuations, and how could we increase awareness on this topic among women social care staff and policy makers. And to give you an example, an insight into our workshop, we have been discussing mood-related side effects and use of hormonal contraceptives. And as you see here, we were agreeing on the fact that there has to be information about this topic. It's a reality, it's an issue, and we need to acknowledge it without hiding it, but also highlighting the risks versus the benefits of using hormonal contraception. And it also came out that women, in a way, can be, so to say, confused because of the very guidance given by gynecologists or healthcare professionals. And we have been also pointing out for the need of more targeted clinical investigations, for instance, to follow up the woman while taking hormonal contraceptives to see how mood adverse symptoms develop, as well as to possibly diverge and diversify the treatment. And as we were also having the discussion together with government representatives from Africa and also clinicians from Asia, we have been discussing about non-Western countries and how structural deficits in the medical system actually contribute to stigma and misinformation regarding this topic. In conclusion, we would like to highlight the tremendous gap in terms of knowledge regarding women's mental health during the reproductive age. And we would like to urge joint and interdisciplinary efforts, not only between various actors, but also within the same level. For instance, between clinicians having different expertises, but treating the same patient or meeting the same woman for counseling regarding hormonal contraceptives, for instance. And thank you.
Thank you, Erika. Thank you so much. And also your full report will come later, and probably and hopefully we will get more knowledge out of that as you wish. So thank you very much for that. And now we turn to the workshops that we had yesterday. And the first one, addressing peripartum depression. Alkistis Salkidou, professor in Department of Women's and Children's Health here at Uppsala University. Are you with us? And please tell us, oh, I can see you. Please tell us about your workshop.
Hi, thank you very much. And thank you for this possibility to summarize our inspiring workshop. Yes, we started off with Professor John Cox, who is a very big name, of course, in this area, who inspired us with his few words. And then we continued with many experts from different fields that you see, but also contributors from patient organizations in Sweden, Norway, and participants from very different countries around the world, as well as WOMHER PhD students. This was the second WOMHER workshop in this summit. So we identified some problems in this area, that depression around childbirth is very prevalent, but it's still underdiagnosed and untreated, even in the Nordic countries. There is still low awareness of the condition for many women, despite them having gone through the whole maternity health system in Sweden. And many are still missing. We are missing them in screening efforts. The stigma is far under there. There is a low availability and of resources. We sometimes have some optimal specialist training in perinatal psychiatry. And then we also identified a lack of transdisciplinary approaches. And of course, that we need more personalized options. We also had a very interesting economic version of this, that women's earnings drop and sick leave increases very drastically after the birth of their first child, and that father's mental health is not addressed, and the whole situation creates a huge cost for families and society. So what the participants felt that we need to focus on was that maybe we need to work more, and I think the workshop by our psychiatric colleagues on the taxonomy and the words we use, using mental health problems, many identified as helping in lifting the stigma from the typical traditional disorders and psychiatric diseases. So maybe this could be a way. The contribution of patient organizations is very big, and that we can use social media to lift awareness. That we can work on more personalized approaches and user-friendly assessment for all cultures. Our societies now are multicultural. That there is a very big value in transdisciplinary approaches, in thinking about the mind as bigger than just the brain, and other such concepts. That we do need to work very, very hard with raising awareness and information among all pregnant women and their providers and authorities and the press. That we need to increase but also evaluate screening in pregnancy and among the partners. That we need to train specialists in perinatal mental health and maybe work in multidisciplinary teams. We also talked about resource and cost-effective solutions. We had this model of the mother-baby units, which is a very costly solution, but maybe we can also use other solutions such as telepsychiatry and robotics, which is a cutting edge research that we have within the Womb-Her Center at the moment. And of course, shift focus instead of trying to treat to early identification and prevention, as Australia is doing. And then lastly, that we need to better understand why women are punished for giving birth. They're punished by having less money and more sick leave. And what can we learn from the pandemic experience where we saw that preterm birth was so much lower? Could we further evaluate if we can use this and use it in policy? Could working from home could be a flexible solution for pregnant women and new mothers? And could other flexible parental leave solutions be more cost effective in the end if they do prevent sick leave later in life? So thank you very much from us and the Womb-Her Center.
Thank you so much. Thank you. And nice to see that you have quite a lot of concrete suggestions on how to move forward. Thank you so much for that. And now to the next workshop, Public Mental Health Promotion as an Integral Part of Clinical and Community Care Programs. Valerie De Marinis, Professor Emerita, Psychology of Religion and Public Health here at the Uppsala University. Can we hear about your workshop, please? Valerie?
Thank you.
Yeah.
Thank you so much. Something just...
We now hear you and see your presentation.
Hear and see.
Excellent.
Thank you very much.
Yeah.
Yes. So our workshop, I can first of all say that we had a wonderful representation from all of the countries that you see on this screen here, and it was led by myself, who, in addition to being Professor Emeritus in Uppsala, I'm a Professor in Public Mental Health, Senior Professor in Umeå, and working in Norway as well, and my colleague, Professor Lars Schlin in Psychiatry. So our workshop, we finalized summing up in different kinds of questions, and I'll very quickly go through them, because we were looking, first of all, at the larger questions about definitions and models and what difference they make. And one of the exciting things, building actually from other things in the conference, was how important it is whether we're using a one-dimensional model with health and well-being, resilience on one end and mental ill health on the other, or the option of two-dimensional model, different diagrams. We were all in agreement that the importance of both mental ill health and mental health concepts such as resilience are very important for interaction in the mental health models. Very important understanding that resilience is affected by sociological changes, and that different models in different contexts present different challenges. We were in agreement for the most part that the dual domain model was much better, but the important thing is most of us are working in mental health with already established models and what it means to change them. So the important thing was to build in different ways to operationalize. Then we went on to looking at distinctions between public health promotion and prevention. And what we found out was very interesting, that here the high income countries and the middle and low income countries, our representatives that were present, we found that there was so many confusions actually around these terms, but different kinds. Some were linguistic, some were related to strength versus risk. So understanding mental health promotion, it's very important to understand both how systems are set up in the cultural and contextual situation, and also what's possible in what is happening. And in many countries, both high and low income, it was agreed that there probably in some ways are more resources, or the understanding more resources should be placed on stages of intervention and specialized population. Not an argument there, but oftentimes it's at the neglect of earlier intervention with youth. And that means we're actually having an iatrogenic system, which is creating more mental distress. And then some responses related to experiencing examples of enabling clinical and community care programs to interact. This was also very interesting. We looked at specific examples that have also come up in the conference, such as the Friendship Bench, wonderful example, others coming up within the Indian context. Important educational programs that can help to avoid stigma, but then stigma needs to be understood in the cultural context because different things created, there are different kinds of stigma. And then I'll move on quickly to the other part of the discussion we had, looking at these kinds of questions on a person-centered approach. Can it be implemented? Should it be implemented in all countries, etc.? And there was large agreement that this approach was best, but especially in several of the low and middle income countries represented, the community centers were felt that they do not have the resources or capacity to work in this way. But also the gaps also exist in high income countries such as Sweden, where it's the golden standard, but not the reality. In addition to a lack of resources and capacity, there's also a challenge among attitudes and orientation. So the philosophy of approach makes a big difference. And then cultural capacity. So we had also that term of mental capacity and cultural capacity. Then how can we secure a place in society for patients? Also, when we went into more the clinical populations and dual diagnoses, that community-based mental health services are not being well developed or funded. And then also there's not a great interaction between the community programs and the more specialized mental health services. And once again here, both cultural and attitudinal dimensions were very much stressed. And then finally, we came to the public health, caring for people with mental health and addiction problems. How do we bring them into civil society and promote this concept of citizenship within the community, and discuss the roles of NGOs having programs for treating substance use, so that NGOs were generally very helpful, but then coordination between NGOs, even INGOs, and then with specialized services in that triangle from community care up to specialized care, there weren't many links being made. Different programs, organizations have their networks, but also operate in silos. And so we're actually being less effective than we could be. So, and then the educational efforts of mind and behavior, there are some that exist and are being used, but also the evaluation and effectiveness on some of the NGO methods, it's not studied in the way that it could be. So a lot of information gets lost. And then finally, all of us, for a very strange thing at the end of the long day yesterday, found a great deal of energy. So we decided that we would move towards thinking about the next step, that clearly this is an area we all have to look at together. We have to make very specific attention to context-specific factors for policy change and policy operationalization. Working with this type of public mental health promotion, we're kind of, it's a newer area, or let's say perhaps a more questioned area in public health research. So it's important to build collaboration and for research and action research. And I'm happy to say that Sweden and Norway already are working together to figure out how we can build on this conference and create a network that will be opened up for both those doing research, practitioners, and policymakers. Thank you very much.
Thank you so much, Valerie, and excellent to hear that you're already talking about the next steps. Very good. Thank you so much. And now I'm joined here in the studio by Joanne Woodford, your researcher, Department of Women's and Children's Health in Uppsala University. And your workshop was how to improve access to evidence-based psychological intervention. Tell us about your workshop.
Yeah, absolutely. So myself and colleagues from the University of Exeter in the UK ran a workshop tackling the rather big question of how we can close the mental health treatment gap. So how we can increase access to psychological therapies with Professor Paul Farrand and Professor Catherine Gallop at Exeter. So just to recap, we had three big aims. So one was to explore how do we actually organise mental health care systems and how can we maybe reorganise them in order to help increase access. We also looked at workforce developments. So what sort of new professional psychological roles could be developed in order to help increase access. And we also spoke about how we can use technology. So how might we be able to use e-mental health as a way to also increase access to psychological treatments? So these were the aims. So in relation to reorganising care, first of all, we discussed some of the challenges that a number of the delegates coming from very different countries, very different contexts were experiencing. One theme was that a lot of the healthcare structures were not national, they were regional. And that meant that there were big differences, disparities in relation to how care was organised and not so joined up. Also, people spoke a lot about how primary and secondary care tended not to be well integrated, and also poor integration with more community organisations as well, so not much joined upness. This resulted in long waiting lists, and also people spoke about financial difficulties when they had insurance-based systems. So lots of challenges. And I'm going to focus on the challenges first and then move on to solutions. Next, we were talking about how we can rethink workforces. So most of the countries who were represented in the workshop had very traditional psychological workforces, psychological professions. So there we're talking about clinical psychologists and cognitive behavioural therapists. Who are highly trained, highly competent, but there are not many of them. So it's really difficult with only those types of roles to actually be able to support everyone who may have a mental health difficulty that requires some sort of support or treatment. So that was a problem. So not many other workforces. However, people also spoke about the difficulties around introducing new workforces and spoke about professional turf wars. So people being worried about the idea of introducing lots of new psychological professions, people being worried about what that would mean for their profession, and this was a big concern. Also, people spoke about challenges around, well, who actually takes control of this? So is this something which is driven by government, by policy changes, or academia, and how does that work? And also, some of the healthcare contacts felt that although it was great to think about the development of new psychological workforces in their systems, medication was the sort of predominant treatment choice. So that would be difficult too in order to justify new professions. And next, we thought about delivery, so technology. And again, we spoke about challenges. So people generally said that in lots of the contexts that were represented in the workshop, that people are using e-mental health more and more. But they also spoke about the technical valley of death. So by that, people were talking about how quickly technology advances, and as soon as it has gone through rigorous research, it's out of date. And also the sort of implementation stage death. So we can have evidence-based interventions that exist, but then it's hard to get them into practice. And people generally said that there were also a lack of recommendations nationally. There was lack of guidance and lack of regulation. So people were really unsure, well, what interventions can we use? And people are not educated. So there's a lack of education for workforces in terms of supporting these interventions. Okay, so Solutions. This is not all of the solutions that we spoke about. There are so many. So generally, we spoke about how, well, people felt that there needed to be like government level, policy level commitment to making big organizational changes and bringing in new workforces. And if you bring in new workforces, they need to be highly trained, consistent training across countries, national curriculums, accredited training courses. People spoke a lot about needing more stakeholder involvement, so working more with people that are going to receive treatments, develop treatments, and also other stakeholders. And stigma was mentioned in the last couple of talks as well, and that was a big theme. And greater consideration of things such as the language that we use in order to increase access to interventions, and also integrating more community organisations, so where people are already. So that's a summary of our solutions.
Thank you. Many questions, many challenges.
Yeah, many.
Yeah. But some solutions as well.
Some solutions to move on with. So that was.
Thank you, and looking forward to the full report later on then.
Thank you.
Thank you so much. And now I'm also here in the studio with Lena Lidfors, Professor of Ethology, Swedish University of Agriculture Science. Welcome.
Thank you very much.
Tell us about your workshop, Animal-Assisted Interventions for Children with Mental Health Challenges in the Schools. Please tell us more.
Let's see if I can get my presentation up.
Yes, I think.
So.
No, I think it's there.
The people who organized this workshop was me and Maria Andersson at the Swedish University of Agriculture Sciences. And we did this together with Laura Hartman at the Uppsala municipality. And this was a very nice collaboration between us three. So the aim with the workshop was to raise different aspects of animal-assisted interventions for pupils of different ages who need extra support to come back to school or to continue going to school. And this is because in Sweden we have more than 20,000 children that have more than 20% time out of school, and some of these pupils actually drop out of school completely. So there is a big challenge for the schools to bring these pupils back to school. And often the schools are trying really hard and they do everything they can by the means they have to bring them back, but sometimes it doesn't work. So then dogs and also horses have been shown to be able to help these pupils to come back to school in collaboration with different teachers, of course. And another aim was to propose practical solutions on how animals can be involved without compromising the work environments in schools or human and animal welfare. And then we come into the One Health, One Welfare aspect, which is very important. And there, sometimes it's brought up that allergies is a hinder to bring dogs to school to help pupils, and different aspects are mentioned. Another aim was to discuss which policy changes are needed and how health economics is affected by having these high dropout rates of pupils and how the animals can support this. So questions were given to the participants in 2 breakout rooms, and the results of this will be brought into this post-conference report. So just to show you how we organized this workshop, we started up with 2 introductory lectures, one by Andrea Bies, professor at the International University of Applied Sciences, who talked about the science behind what happens with children when they don't feel at home in school anymore, and how the animals can support them, and how the brains actually works for learning. A new word was learned, neurodidactics, which is very interesting, how actually humans learn things. And I think that is something schools really need to think more about, because the school environment needs to support the kids for this. Then we had Michael Kaufman. He's a program director at Green Chimneys at Brewster in New York State. And he's actually running a school for all these dropout kids in the whole state of New York City. They have about 200 pupils going to, it's like a farm with a lot of animals, gardening, they're helping injured birds, and they help shelter dogs and so on. Then we had 2 breakout rooms, so we were not ourselves in these breakout rooms. The groups had to discuss themselves the questions given to them. And then they came back to the rooms, and actually then we kept Andrea Beetz and Michael Kaufman in the room, so they were asked to answer the questions from the breakout room. So we had a very nice discussion in the large room. Then to bring you to the take-home message. So these are the main thing that we have brought together. So compare societal costs of not finishing school to cost of intervention. So use estimates of effect of intervention was one thing that was brought up. Then another group said that saving costs is not necessary. If we can show health gains like quality of life, that is also important. So not only looking at the money. Another conclusion was individualized interventions, animal as a complement, the use of multidisciplinary team. So we should not see the animal as the treater, but it's more like the animal is helping the teacher to help the students to support them in the school. One conclusion was analyze the learning environment in schools. What can animals bring in? So sometimes animals are working alone with pupils and sometimes in the whole class. And then there were neurodidactics, how do human brains learn? How can animals facilitate that? And the last thing, people working with animals need to have knowledge of the animals. So risk assessments, both for the human health and the animal health. So that was, in summary, the take-home message from our workshop.
Thank you so much. And we also look forward to the full report later on then.
Yeah.
Thank you so much for this.
Yeah.
And that concludes all the workshops. So thank you for all participants in the workshop and all the work that you've been doing. And as I said several times, we now look forward to the post-conference report.